Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Good morning, everyone. Welcome to this edition of the Wellness Webinar with the Hindu and Naruvi Hospital. Today, we'll be talking about living well with kidney disease. We have on our panel 3 nephrologists. Dr. V.C. Annamalai graduated from MBBS and MD in General Medicine from the Madras Medical College. After working for a couple of years in a private medical college as assistant professor of medicine, he did DM nephrology in Christian Medical College, Vellore, and worked there as assistant professor of nephrology. He had passed the European specialty examination in nephrology, which is delivered jointly by the European Renal Association, the European Section and Board of Nephrology, the UK Kidney Association, and the Federation of the Royal Colleges of Physicians of the UK. He has a comprehensive skill set to manage patients with problems ranging from acute kidney injury to end-stage kidney disease, including managing several types of I'm sorry, I'm not getting this right, nephritis, and care for kidney transplant patients. He's a keen clinician and equally a keen researcher. His special interest is in preventive nephrology. He will speak on living well with chronic kidney disease. Welcome, Doctor. Dr. Goli Sri Charan Nivas did his MBBS at Sri Devraj Ers Medical College in Kolar and pursued his MD Pediatrics in Datta Meghe Institute of Medical Sciences in Wardha, Maharashtra. After completing his post-graduation, he worked for a year in the same medical college as a senior resident and for another year as an assistant professor at Geetham Medical College in Visakhapatnam. He went on to specialize in nephrology by completing DM nephrology at Andhra Medical College, Visakhapatnam. An astute clinician, his special interest is dialysis and transplant. He will speak on living well on dialysis. Welcome, Doctor.
Thank you, madam.
Dr. Krishna Chaitanya completed MBBS from Narayana Medical College, Nellore, Andhra Pradesh, and post-graduation in internal medicine from Southern Railway Headquarters Hospital, Perambur, Chennai. He took up nephrology as a subspecialty in Apollo Hospitals, Chennai. Dr. Chaitanya did a fellowship in interventional nephrology at CMC Vellore and holds an MRCP UK diploma. His experience includes working as a physician and a nephrologist. He is currently a consultant nephrologist at the Asian Institute of Nephrology and Urology, Chennai. He'll speak on living well with transplanted kidney. Welcome, Doctor.
Thank you.
I request Dr. Annamalai to please start with his presentation.
Thank you, ma'am. Thanks for the kind introduction and good morning to all. At the outset, I thank our clairvoyant chairman, Dr. G.V. Sampath, rest of the Naruvi management, as well as the Hindu team for giving us all this opportunity to make this presentation. So, I will be talking about living well with chronic kidney disease. Though the overall topic was living well with kidney disease, all three of us have restricted us to the component of managing chronic kidney disease, because kidney disease per se is a very vast topic ranging from acute kidney injury, renal stone disease, as well as chronic kidney disease. So chronic kidney disease is just one spectrum of kidney problems which we commonly encounter in our day-to-day practice. So chronic kidney disease, shortly CKD, is a silent problem, and people usually don't notice any problems early on. They will be asymptomatic, or they won't have any troubling symptoms during the early course of the illness. But even though it remains asymptomatic, it can cause damage to the body without the patient's notice, and eventually it can get worse, and finally the patient starts feeling bad. So the key here is to recognize the disease early. So patients who are at high risk, like those who have diabetes mellitus or high blood pressure, or those who have a family history of kidney disease, or those who are overweight and obese, it is advisable for them to get an early screening for the presence of kidney disease, so that once the problem is detected early, there is much to be done to save the remaining kidney function. So the early detection will be a very key importance here. So as I said, most people do not have any problems in the early stages, but some people may experience foamy or soapy urine when they pass urine, or they may have their legs swollen, or they may notice puffiness around the eyes or facial puffiness in the early morning especially, or they tend to develop symptoms pertaining to the development of anemia. That is, they may get easy fatigability or tiredness or breathlessness on exertion, symptoms related to anemia. And they are also at higher risk of developing heart disease as well as developing stroke. And they may also have bone problems later on, especially the bones tend to become fragile, and they will be facing even trivial trauma causing fractures. So once a patient notices that he has a kidney issue, the key for preventing the disease from progressing will be to either to regular appointments with the kidney doctor, because the kidney doctor can help the patient in slowing down the progression of the chronic kidney disease. And once the kidney part is taken care of, it is indirectly contributing to the health of the heart, bones, and rest of the body. And people need not stigmatize themselves, or the society need not stigmatize a patient with kidney ailment, because not all patients who visit a kidney doctor will be having a kidney which has almost stopped working. So seeing a kidney doctor does not mean that the kidneys have totally stopped working. And it does not mean that one will directly need dialysis or kidney transplant in the initial visits only. So the kidney doctor can make sure that the patient's kidney work well for as long as possible with so many conservative measures in the form of dietary adjustment, medications, lifestyle modifications, so that the patient does not reach the last stage, end stage kidney disease very quickly. So, and a dietitian's role is also important in helping the patient with having a proper meal plan. So what one eats and drinks is also one way of controlling the rapidity of kidney disease progression. And these are some of the things which a patient can do to prevent the CKD from getting worse, like taking care of other health conditions. Like if the patient is already a diabetic, or a patient with high blood pressure, or a patient with a cardiac ailment, taking care of the primary illness will be indirectly helping the kidney from progressing towards advanced stage of chronic kidney disease. Eating right, especially less consumption of salt, and having a caution about phosphorus intake or potassium intake later on will be helpful. And the amount of fluid intake. In early stages of chronic kidney disease, the patient may not restrict much with respect to the diet as well as fluid. But once the kidney disease advances into higher stages, it is advisable to cut down on the fluid intake as well as keep an eye on phosphorus potassium intakes. And the physical activity has a major role in preventing CKD from progressing fast. So spending good amount of time in physical activity as much as tolerated is also important. That will indirectly help in reducing overweight. So staying at a healthy weight and avoiding over-the-counter medications like painkillers, especially like NSAIDs, or some of the alternate medications may contain heavy metals which can harm the kidneys. So we have to be aware about what exactly we are taking in. The ingredients of alternative medications sometimes may contain harmful substances which can harm the kidney. And smoking can reduce the blood flow to the kidneys. So smoking cessation is of paramount importance in preventing the CKD from progressing to advanced stages. So as I said, drinking enough water, especially in the early stages of CKD, there will not be a need for much fluid restriction. So a patient with kidney disease, or even otherwise an healthy patient, should make sure that he or she is drinking enough water. And following a heart healthy diet, especially in the form of reduction in the saturated fat, is very important for cardiovascular health, and it can help the kidneys as well. And reducing the amount of sodium chloride, that is table salt, is also of paramount importance in achieving control of high blood pressure, as well as it will indirectly help in the workload of the kidney, thereby preventing the rapid progression of chronic kidney disease. Some of the patients are already aware of salt substitutes, like which is low sodium salt, which may contain potassium chloride as a substitute for sodium chloride, but it does not fit everyone. Some of the patients, otherwise healthy people, can take all this potassium containing salt substitutes, but it may not be advisable for patients with advanced chronic kidney disease, where they have to be cautious about high potassium in the blood, which can push them into emergency dialysis. So salt substitutes, one has to be careful, and it has to be used after discussing with one's doctor. And like every time a patient with kidney disease meets a doctor, it is better to bring all the prescription medications as well as over-the-counter medication which he or she is regularly taking, so that the kidney doctor is aware of whether all the drugs are safe to the kidneys and whether the interactions are also safe to the kidneys. Same way, if the patient with the kidney disease has to meet any other doctor also, it is better to tell the doctor that he is already having a kidney ailment, so that the doctor who is seeing the patient for other ailments also will be aware about the kidney problem, and they can prescribe medicines which can suit the kidney patient. So these are some of the ways in which one can live better with a kidney disease. After the diagnosis of a kidney disease, these are the ways in which one can improve the lifestyle, improve the practice, so that he can feel better. So once one starts living better, the patient can feel better too. So these are some of the concepts of how to live well after a diagnosis of kidney disease. And my colleagues will speak once the kidney disease advances to a stage where it demands kidney assisting therapy or kidney replacement therapy in the form of dialysis or a kidney transplant. My colleagues will throw more light on those topics. So thank you for this opportunity.
Thank you, Dr. Annamalai. I request Dr. Goli Charan to please start his presentation.
Yeah. Thank you, madam. Yeah. Good morning, one and all. Thank you, Dr. Annamalai, for having a great talk about CKD. And I want to thank the Hindu group, along with the Naruvi management, along with our beloved Naruvi chairman, for allowing me to talk about living well with kidney disease. Especially, I will be talking about living well with kidney disease on dialysis. This is a topic that is really close to my heart. I hope by the end of the speech, you will have a better understanding of what it means to live well with kidney disease on dialysis. Okay, first off, let me start by saying that dialysis is a life-saving procedure that can help people with kidney failure to stay alive. So if you or somehow you or your relative is on dialysis, give yourself a pat on the back for being a warrior. Okay, so dialysis has actually started almost 5 decades ago. Now there are almost more than 2 lakh people on dialysis. There are mainly 2 modes of dialysis. One is hemodialysis and the other being peritoneal dialysis. If we look at the history of dialysis per se, first successful dialysis procedure was performed in 1943 by Dr. William Kolff. He was a Dutch physician. He actually treated a 67-year-old lady, and dialysis helped her to live for additional 11 days. So they were happy about that, the dialysis has helped that lady, a 67-year-old lady, to live additionally for 11 days. So dialysis is not it has to be like it. It is not a permanent solution, or it can't replace a native kidney. But it is definitely possible for us or for the patients to live well and live happily and have a quality life even on dialysis. So by 1970s, Kolff and Scribner work paved the way for creation of more advanced dialysis machines. In today, if you see in government hospitals in India, they provide free treatment to poor patients with chronic kidney disease. However, because of some inadequate funding and because of lack of health insurance schemes, these pose a serious hurdles in providing these dialysis. In contrast, if you see in private hospitals and corporate hospitals, they're providing state-of-art dialysis and transplantation facilities, similar to advanced centers of the world. But these are only accessible to a very low group, that is very only an upper income group. Okay. Now let's get on to the fun stuff. Yeah, I said fun stuff. Living well with kidney disease means enjoying life to the fullest, even with a dialysis machine attached to you. Okay, kidney disease can affect anyone, regardless of age and gender or anything. It's a condition where your kidneys lose their function to filter the waste products from the blood. As a result, these toxins, which are present, accumulate in the body, leading to various complications such as a raised BP, low hemoglobin, fluid congestion, etc. So dialysis is a one way to treat this kidney disease. What dialysis is doing is to remove all this waste material from the body, but don't think it is a cure. It's only doing the job of the kidney. So until the patient is on dialysis, he will be doing fine. If once the patient go into ESRD means end stage. I mean, the kidney function is completely lost. So it is important for the public to understand the risks and benefits of dialysis, as well as the importance of early detection and the prevention of kidney disease, as our Dr. Annamale has previously mentioned. Okay, it is estimated that around over 1 million of people all over the world are requiring dialysis treatment to survive. This number is only expected to rise in coming years, especially with increase in CKD, increase in diabetes, and other health issues. And this COVID also has pushed so many people into ESRD who are previously a case of CKD. So what does it mean to live well with kidney disease on dialysis? First, it means you have to embrace the healthy lifestyle. What you eat, what you drink play a significant role, as well as how much you eat. So the important aspect of living well in dialysis is also eating well. This means following a kidney-friendly diet. But don't worry, you can still enjoy all the delicious and healthy meals. Just to be creative with your food, and add some more spices and herbs to your food, and add more flavor to your food. Furthermore, incorporating physical activity into your daily routine can also improve your overall quality of life and reduce your stress and control your BP. Secondly, it means that you need to be proactive about your health care. Regular dialysis sessions are always critical to maintaining your health when you are on dialysis. But that is only one aspect of your care. But you should be closely monitoring with your health, closely working with your healthcare team to ensure that your treatment plans meet your needs. This means attending your appointments, following prescribed medications, and raising concerns if there are any immediately. And it may also help you to join a support group or talk to a fellow patients who are also having a kidney disease on dialysis. Sometimes it can be tough to navigate life with kidney disease, especially when it requires dialysis. So sharing your experiences with others can help normalize your situation and make you feel less lonely. So one of the best ways to live well with kidney disease is to stay active. Exercise is a great for your overall health, and it can help you to manage stress and anxiety. You don't have to run a marathon. Just try to do some walking, and try a yoga, or try a new hobby like even swimming. Don't forget to socialize. Dialysis can be a lonely experience sometimes, but it doesn't have to be. Join a support group, take a class, join a community, surround yourself with positive and supportive people, and make yourself a overall well-being. And living well with dialysis is possible. It just takes a little effort and lot of positivity. To give some examples, I would like to quote Alonso Mourning. Alonso Mourning is a former professional basketball player who was diagnosed with a kidney disease in 2000. He underwent a kidney transplant in 2003, but unfortunately the transplant failed and he was put on dialysis. Despite these setbacks, Mourning continued to play basketball. Mohan continued to play basketball, and he was named the NBA's Defensive Player of the Year in 2004. He eventually received a second transplant, and now he continues to be an advocate for kidney disease awareness. But see, even he could play a contact sport like basketball, which so it is possible to live well with kidney disease. Even in India, we have great superstar who underwent two transplants. Still, he is effective on screen, and he's awesome on screen, in fact, and he has so many hits even after transplant. So it is possible, and you have to just have that quality, and you have to have that vigor. You have to have these things to improve your overall health. Coming to hemodialysis and peritoneal dialysis, I just want to give a brief thing. What is hemodialysis and what is peritoneal dialysis? So hemodialysis, here the blood goes via a fistula into the tubing, into the machine, where we clean all the waste material. So people will be usually advised to be on either twice or thrice weekly dialysis based on the urine output and the patient needs. And peritoneal dialysis. So coming to peritoneal dialysis in the by 1980s, peritoneal dialysis became a very popular alternative to hemodialysis. So peritoneal dialysis is a type of dialysis that involves usually lining of the abdomen as a filter to remove these waste material and excess fluids from the body. This type of dialysis has several benefits compared to the hemodialysis, and it may also increase the overall quality of life. Peritoneal dialysis can also provide some amount of flexibility to the treatment schedules. Patient can perform their activities, that is any activities, allowing them to work, attend any events without any interruption. Additionally, peritoneal dialysis allows for better BP control, and it may lead to improved overall health. Another significant advantage of peritoneal dialysis over normal hemodialysis is that patients do not require an access site such as a fistula or a graft. These are usually ports for hemodialysis to occur. So they do not require these ports to get. But we have to do peritoneal dialysis with the help of a artificial catheter, which should be introduced into the abdomen. And peritoneal dialysis can also provide a better quality of life for patients. And patients who receive peritoneal dialysis may experience fewer side effects compared to hemodialysis. Not always, but sometimes. And another important dialysis, which is recently coming up, is home hemodialysis. So what is home hemodialysis? So this allows patients to receive dialysis treatment in the comfort of their own homes. Now, this is an alternative to in-center hemodialysis, and it provides patients with more flexibility, control, and convenience over the treatment schedule, while improving the overall quality of life. One of the most significant benefit of home hemodialysis is the ability to have more control over one's treatment schedule. Patients who are undergoing in-center hemodialysis, typically they will be having either thrice weekly or twice weekly. They have to schedule their appointments 2 days before or 3 days before, and all these things has to happen. So this home hemodialysis will help this to bring normalcy to their professional as well as the personal lives. And these days I could see in upper class and upper middle class even, and I could see most of the cities are having Creta cars with them. And as we know, Creta car is already like 15 lakhs or 20 lakhs. It is going up. Car cost is going up. And if you see hemodialysis machine, it is only 6 to 7 lakhs. And a small water treatment plant can be made at home even. That it will cost around 1 or 2 lakh maybe. And some routine daily use equipment like a dialysis membrane, a dialysis equipment per se, which are daily consumables, will cost around 1,000 per session. And we can hire one of the technician at home who he will be costing around 500 to 1,000 rupees. So instead of buying a Creta car, I think people can even buy a hemodialysis machine at home, and they can keep that hemodialysis machine at home. So don't think that dialysis is a costly affair and only upper class and high class people can afford it. No, I think really denied, because even in villages people are having cars, right? So yes, dialysis can be done in villages also, right, if all the equipments are taken care of. So this is the benefit of home hemodialysis, is actually it increases the convenience. So patient who receive treatment at home no longer need to commute to the dialysis center, and he can wait, he can be at their home, and they can have a cozy bed at their home, so that they will be more happy. So it will improve the flexibility, convenience, and everything. Home dialysis can also improve the patient's overall quality of life. They will have less anxiety, less stress, and associated with which are associated with dialysis process. So while home hemodialysis have many benefits, it's important to note that it is not suitable for everyone. Patients who are interested in this treatment must undergo a thorough evaluation by the healthcare provider to determine whether they are eligible or not. Additionally, patients who opt for home hemodialysis must receive extensive training and education on how to operate and maintain their equipment, as well as adhere to strict infection control possible. Okay. Lastly, it is essential to stay committed to their goals, and remain positive through this journey. Dialysis can be overwhelming, exhausting, and keeping a positive outlook, setting small achievable goals can help you to stay motivated and engage in your care. So it is important for public to understand the risks and benefit of dialysis, and it is important for public to understand that living well with kidney disease on dialysis is possible. Thank you.
Thank you, sir. That was quite interesting. You made it sound like it's so easy to just be on dialysis and nothing will happen to you. When kidney disease itself is so scary. But it was so interesting to listen to you. Dr. Krishna
you.
Chaitanya, would you please present your...
Yeah. Good morning, everyone. Thank you very much, Naruvi management and the Hindu, for inviting me for this talk here on wellness series in kidney, in the Hindu, on kidney diseases and health. Dr. Charan and Dr. Annamalai, those were very good talks. Enjoyed them. So now I'll come to my talk. Why kidney transplantation? So we have heard managing well on CKD, managing well with CKD, managing well on hemodialysis, but why kidney transplantation? So before that, I would like to tell that a kidney transplant is just a treatment for kidney failure, but it is not a cure. So it also forms part of the renal replacement therapy. It does not replace the previous ailment. So the ailment which has caused the kidney failure is still there. It's just a replacement for the ailment. And definitely, why is it, does it score over hemodialysis or peritoneal dialysis? The answer is a definite yes. It doesn't mean that everybody has to go for transplant, and you have to see whether it is possible. There are other factors which I'll be coming to later in a later slide. So what does a transplant offer? It offers a more active life, freedom from hemodialysis or peritoneal dialysis, freedom from restrictions of the fluid and the dietary, whatever restrictions they are, you definitely get freedom from it. And it definitely gives you a mortality benefit. The longevity is definitely high with renal transplantation. So who can undergo renal transplantation? People who have reached end-stage renal diseases or on hemodialysis or on peritoneal dialysis, or the relatively newer concept is preemptive transplantation. People who have not yet reached end-stage renal diseases, they have live-related donor who is willing to donate kidney for them. So they've seen that people who undergo preemptive kidney transplantation might actually do better than people who undergo transplantation after being on dialysis. So as we all can understand, the donor is the most important person because he's the one who is donating you the kidney for a very noble cause. So who all can be donors? As per the government, only a near relative can be a donor. When you mean near relative, it's a first degree relative. Parents, siblings, children, and even spouse is considered a near relative. So recently, even grandparents have been added to this group. So it would be preferable that the donor has the similar blood group, but recently across the blood group transplantations have been happening in a very large amount of centers also. So it's very important that the donor does not have any diabetes, hypertension, obesity, renal issues before donating the kidney. In the sense that he'll be screened for all of these. And it's very essential that the donor will require periodic follow-up even after the kidney transplantation, so that if any element occurs in him, or if we diagnose any hypertension or anything of that sort, it will be addressed faster, and that they do not develop any kidney related or any other elements at a later date. So what is the process? The process of renal transplantation involves 3 steps: pre-transplantation evaluation, transplantation and recovery, and post-transplantation management. So the pre-transplantation evaluation is the part where you see your nephrologist and the transplant coordinator initially, and along with them a team of other doctors who will be assessing the fitness of the donor as well as the recipient, whether they are fit for the surgery. And then your immunological risk also will be assessed, whether you will be accepting the kidney which is given to you. So next step is the kidney transplantation and recovery. The kidney transplantation per se, you will be admitted there. There will be a donor nephrectomy. That means the kidney of the donor will be removed and it will be stitched to the blood vessels of the recipient. And the total stay, when everything goes well, will be almost for a week, and then you will be discharged. Then comes the post-transplantation management, or the post-transplantation period, which is basically divided into 2 parts. The early part, which is mostly for 3 months. That's the early part. And then the late part is after the 3 months. The early part is usually the most important period, wherein the number of the visits to the hospital will be significantly high. The frequency will be quite high in the initial weeks. And then as the graft stabilizes, the frequency comes down. So what are all the concerns during the early post-transplantation period? The most important concerns are the drug-related adverse effects, graft dysfunctions. Every time you go and see your doctor, they'll be assessing all these things, whether your graft is functioning well by measuring the serum creatinine and the urine output. The concerns, if there is a graft dysfunction, it involves whether there is any underlying rejection or recurrence or anything else. And you're more prone for infections during the early transplantation period. And there could be incidences of post-transplantation diabetes mellitus, and also recurrence of the native disease in the graft kidney. So this is a slide figure which I've taken from the KDIGO guideline. So it shows various tests which will be done when you see your doctor, as well as the frequency. As you see, the frequency is higher during the initial months, and as the graft stabilizes, the frequency of visits as well as the investigations comes down. So it's very important when you undergo a kidney transplant, very important that you know your immunosuppressive medication. They are your friends. So it's more like a double-edged sword. Too much of immunosuppression can lead to side effects, and little less of immunosuppression can cause rejection. That means yourself not accepting the graft kidney. You have to be extremely familiar with the dosages, the names, because you'll be ending up taking them lifelong and daily. So you also have to be aware of the drug interactions, other drug interactions, food interactions, and because you're on immunosuppressive medications, you will also be given vaccinations prior to and even after the transplantation, as well as chemoprophylaxis. That means some drugs which are given to prevent infections. So these are some of the toxicity profiles of the immunosuppressive medication. There are a whole lot of them: new onset diabetes mellitus, cholesterol's going high, hypertension, that means the BP increasing, bones getting weakening, anemia, wound healing, and even the kidney dysfunction. The medicines per se can cause some amount of kidney dysfunction. So why is it displayed here? It's not to scare you, but to make you aware. The whole point is that you have to be aware of what you're taking, what could be happening, and so that you'll approach the doctor at the earliest, and the doctor can look at you and assess what's happening and change accordingly and keep you well. So the most important aspect, as I mentioned earlier, after the kidney transplantation is immunosuppressive medications. So again, why I'm stressing here is that is the only thing that keeps your graft healthy. That's the primordial thing. So when you mean we see that almost 30 to 50% of population in India have non-adherence. It's mostly in the most of the causes for non-adherence are financial constraints, especially in the lower income group, lack of knowledge, forgetfulness. The most important thing is experimentation and compliance. See, as you start feeling well, 6 months pass, 1 year pass, 2 year pass, then you feel compliant. You feel okay, nothing has happening, everything is good, I'm doing well. Then you start slowly cutting down the medications or skipping the medications, which has to be avoided at any cost to make sure your long-term the kidney graft function is well. So, and then I've mentioned prior about the infections. Infections are basically because of the immunosuppressive medications which you take. The lung and the urinary tract infections are the things which are most common. And then you have to be aware of the symptoms and approach your doctor at the earliest. I mentioned about the vaccinations which you have to follow even after the transplantation. And then the chemoprophylaxis, which has to be given in the initial transplantation period and even later also if necessary. So most of the people who undergo transplantation are quite worried about rejection. So why does it happen? So usually when before the transplantation happens, the immunological workup is done efficiently so that we can diagnose the possibility of a rejection, whether there is compatibility between the donor and the recipient. Only after that, the transplantation is taken ahead. So even in spite of that, there are increased incidence of rejections during the early period, mostly up to the 6 months of time. So how is it diagnosed? Usually a rejection is diagnosed by minimal increase in serum creatinine in the initial stages, and at the later stages, the urine output might fall. So it's very important that you keep your visits regularly with the doctor. So they are diagnosed by kidney biopsy, and again, they are treated with high dose immunosuppressions and high dose steroids. So every episode of rejection will have an impact on the long-term graft function. So it is very, very important for you to live well, that you take your medication correctly and you follow your regular visits with your doctor. So coming to the late post-transplantation period, here, most of the times the graft is settled, you are fine, the creatinine is normal, you start going to work. And then the other things set in, like the metabolic abnormalities, the post-transplantation diabetes because of the steroids or the tacrolimus medication which is taken, the hypertension, the coronary vascular diseases. So we have heard earlier that coronary vascular disease is quite common in CKD, and it is even higher in hemodialysis. But fortunately, it is slightly lower in transplantation, but it is significantly high than when compared to the general population. So you have to keep monitoring, the doctor will keep monitoring you, looking for all the parameters which can cause coronary vascular disease and address them. Also, I've put in cancer, not to scare you, but one of the side effects of immunosuppressive medication over a long term is one of this. Not that we don't see it very often, but you have to be aware of this. And why is it that you have to be aware? Again, what is important is that you have to see your doctor on a regular basis. This is the reason for sharing this. So what can you do about yourself? Other than medication, what is your part? Your part is that you keep a healthy lifestyle again, whether you are having a chronic kidney disease, whether you're on hemodialysis or peritoneal dialysis, or whether you have undergone a renal transplantation. This part is entirely on you. How do you keep yourself well? So it's about your lifestyle. So adequate water intake. Here, the kidney requires adequate hydration. You should not be dehydrated. 2 to 2.5 liters of water per day. Increase the water intake during the summer months. Low salt intake, 5 grams of salt per day. Weight control. You can, the medication which you take for the preventing rejection can cause weight control. So you have to be aware of that, and you can take the help of your doctor, the dietitian, the physiotherapist to control your weight. Freshly prepared food to prevent infections, avoid smoking and alcohol as mentioned by previous doctors, adequate exercise. So all these things will keep you healthy even with the medications you take. So the take-home message about living well with renal transplantation is judicious follow-up, awareness, adherence to medication, and healthy lifestyle. So these are all the things which can keep you healthy. So it definitely, it's not that everything is not smooth. There will be ups and downs. You need a lot of social and emotional support from your family, from the doctor, from the society to keep yourself healthy. And things have improved definitely. And the longevity also has improved significantly. Thank you very much.
Thank you, Doctor. Thank you so much. We have quite a few questions here, but before we start the questions here, I have some questions on how can you make on maintenance hemodialysis. Can it be stopped once it has been started? This is for Dr. Charan.
Maintenance hemodialysis, there are two types of kidney injury. Actually, people has to be aware of that. One is acute kidney injury and other is chronic kidney disease. And one is acute kidney injury where the size of the kidney will be normal because of some insult like some fever, some fever or secondary to some infection, secondary to some other illness. There can be some acute deterioration of kidney function. But once this illness or some such as pancreatitis, pancreas problem or heart problem, because of these problems, there will be acute deterioration. There will be sudden deterioration of kidney function. Once this illness is taken care of, slowly again the kidney function will come up. This is called acute kidney injury. So always kidney injury and kidney failure requiring dialysis does not mean he will be on long-term hemodialysis. There is this aspect of acute kidney injury, and eventually the kidney improves completely. Sometimes kidney improves completely and people will be out of dialysis. And there is another aspect called CKD where we are more concerned, because slowly they will be progressing over a period of months to years, and slowly they will progress into end stage kidney disease. End stage kidney disease means now the complete functionality of the kidney has reduced, and now these patients are on slowly went on to dialysis. And this is a point of no return until unless eventually they are planning a kidney transplant, when we can finally remove this dialysis machine and they can go on to do a transplant. Otherwise, if they are a chronic case of chronic disease, if there is a case of CKD, eventually leading into dialysis, so they should be on dialysis till they are alive.
Thank you, sir. And I also have another question. That some people go on dialysis for twice a week or thrice a week. How do you, especially for maintenance, how do you decide on that?
Decision regarding whether to take it 2 times dialysis or 3 times dialysis per week will be based on number of criteria. Some of the criteria, most of the time, it will be decided by the doctor who will be treating them. And the basis, how we will be deciding is, most of the time we will be seeing a number of aspects. One thing we'll be calling it as incremental hemodialysis. Why we are calling it as incremental is, initially to start with, the patient who went on to dialysis may be having good amount of urine output. Urine output means good amount of urine volume. So in urine volume, so the quantity of urine is good, but the quality of urine is poor. So the quality and quantity should be taken care of. When the quantity is good, so volume, if we are taking 1 liter of fluid, 1 liter, and the patient is passing 800 ml of urine, so then the balance is not much. It is only 200 ml, which will be utilized by the body for routine needs. But if quantity is very less, slowly what happens is this urine output during dialysis, over a period of time, the urine output comes down. And eventually, the urine volume will come down. Urine output means urine volume will come down to 200 ml, 100 ml. Then with the help of dialysis, we need to remove a lot of fluid. So then we may need to keep them on 3 times per week instead of 2 times per week. So the decision of 2 times per week and 3 times per week will be based on number of aspects. One aspect is urine output. The other aspects like the appetite, how is the appetite, how there are any uremic features, how is the phosphorus control, because phosphorus is another substance which will be taken care by the kidney, and phosphorus has to be removed by the kidney. When somebody is having some amount of residual kidney function, with the help of some urine output, they will be having good phosphorus control. If this phosphorus control is not improper, or phosphorus is at a very higher level in the body, then they need to be on thrice weekly, 3 times. And eventually, even some people may need 4 weeks or 5 weeks, 5 times per week also. So initially, we may start on with 2 or 3 weeks, but according to the patient needs, patient clinical parameters, patient urine output, all these things will be decided based on the consulting nephrologist.
Thank you, Doctor. Dr. Krishna,
Thank you.
I have some questions for you. The question is, will the original kidney disease come back once you have transplanted the kidney?
Yeah, see, what happens is there are many varieties of kidney diseases. The answer is a definite yes, it comes back. But how soon does it come back is the question. So there are diseases which can come back very faster. There are diseases which can come back at a very later date. And there are diseases which might not recur at all. So yeah, that's why it is very important that you talk to your doctor before the transplantation and know what was your disease. So you ask somebody, you have a kidney problem. The first question when somebody comes to you, they've already diagnosed you have chronic kidney disease. The first question doctor asks is, what is your kidney problem? So most of the times the answer you get back is kidney problem. They do not know what is the kidney problem due to. So that awareness has to be brought into the population. Any person who has any kidney ailment has to know what exactly it is, what will it lead to, and is there a possibility of getting it back again. So there are certain things like definitely diabetes and hypertension. It can affect the graft kidney. It can come back if it is not under control, but it will take time. There are certain diseases which can come back very faster and which needs definite monitoring. That is the reason, as I mentioned earlier, immediately after transplantation, there is frequent monitoring to assess whether the kidney disease is going to come back.
Thank you, doctor. I have another question for you. We are talking about paired kidney donation.
Yeah, that's that's a recent thing which has come up. See, what happens is when a person is going for a kidney transplantation, the donor and the recipient together are called a pair. Why you called a pair? Because the donor is donating the kidney and the recipient is receiving the kidney. So as I mentioned earlier, battery of tests are done to look at the compatibility between them. So what is the probability that the recipient will accept the kidney and will not reject the kidney? There could be many probabilities. It could be across the group. That means the blood groups are not related. Or it could be an immunological barrier. That means we do immunological testing for the recipient and the donor's blood, and we assess how much of immunity the recipient can develop or is going to mount against the donor. So if suppose we feel the risk is high, we do not transplant, we do not go ahead with the transplantation. So in this scenario, what happens to them? What is it the end? No. So they have come up with something called a paid kidney donation. When you mean paid kidney donation, you have another pair like this. You have another pair wherein the donor and the recipient are not compatible. There could be many pairs. So what happens is each pair will be looked into, whether the recipient of this pair can get a donor from can get the kidney from the other pair, and vice versa. It could be because of the blood group. Currently, the across the blood group is happening quite frequently. Mostly now it could be because of the immunological barrier. So with that, the necessity for the higher immunosuppressive medications comes down when the compatibility is good, and then the longevity of the kidney improves. So it has come up and it's being done at many centers, even in our country.
Thank you, Doctor. Dr. Annamalai, I have some questions for you. We have been talking about chronic kidney disease all along, but what exactly is chronic kidney disease and when does it actually become chronic? I mean, what kind of symptoms can we look for? Should we look for, I should say?
Sure, ma'am. As against acute kidney injury, which is sudden loss of kidney function, chronic kidney disease is a progressive loss of kidney function. Unfortunately, it is asymptomatic in the initial stages for most of the patients. So that's why we have to screen patients who are at high risk of developing kidney disease, as I mentioned, like those who are having diabetes mellitus, that is high blood sugar, or those who are having systemic hypertension or elevated blood pressure, or those who are having overweight or obesity, or those who have a family history of kidney disease, like any of their near relatives having a kidney issue. These are the high risk group or vulnerable group whom should be targeted for early detection in the form of health screening. So nowadays, once anybody reaches age 30, it is advisable to undergo one full body checkup at least once a year, so that especially these high risk group, overall affordable more than 30 they can do, but at least these high risk patient, high risk population, they should definitely undergo screening, because initial stages like CKD is having 5 stages, and most of them may be asymptomatic still, even stage 3, stage 4 also. CKD stage 1, 2, 3, 4, 5. So most of the symptoms start by stage 4 or 5. So stage 1, 2, 3 may be largely asymptomatic. So only by appropriate screening we have to look for. We cannot entirely rely upon the development of symptoms. By the time one has started developing symptoms, at least 50 to 60% of the kidney function would have been lost, because it is enough for anybody to live with even a single kidney. So even if 50% of the kidney is donated to someone else, a person can live with only one kidney. So like that, even if the 50% of the kidney function is lost, the patients may remain largely asymptomatic. So there comes a role for early checking, early testing, and screening, so that the patient should not come at the time when they started developing symptoms, they may have 60 to 70% of their kidney function already lost.
Thank you, doctor. So I have another question for you. Is there a way when if somebody is a CKD, has chronic kidney disease, can you prevent it from getting worse?
Definitely, for some of the illnesses will be very slowly progressive, and when they are timely detected, much can be done to prevent the progression from being faster. For example, a good glycemic control in a diabetic patient, or an adequate BP control in a patient with uncontrolled blood pressure, they can really save the kidneys from progressing faster towards reaching the end-stage kidney disease, or a stage which requires kidney assisting therapy or kidney replacement therapy in the form of dialysis or kidney transplant. So early detection again is the clue where we can do so many things. For example, some of the diseases like glomerulonephritis, when detected early, medications can be given to keep it under control, what we term as complete remission, like that, or sometimes some patients achieve partial remission. Even whatever is salvageable can be offered to the patient only when they come to us in an early stage. Much can be done to prevent the rapid deterioration.
Okay. Thank you, sir. So I have one question. All of you have been saying you must drink a lot of water. You must remain hydrated. What is the ideal amount of water a person should drink in a day to prevent kidneys from getting damaged?
Shall I take this?
Yes, sir.
Yeah. See, the obligatory amount of water somebody has to take per day is minimum of 500 ml. 500 ml is required by the kidney to get the whatever the waste metabolic products out. Other than this 500 ml, you will be losing water through respiration, through evaporation, all those means, and through the cellular metabolism. So that you can put it another 500 ml. 1 liter should do, but it depends on the external atmosphere. So when it comes to external atmosphere, in countries like ours, it depends on the occupation or your exposure. If you're in an air conditioning, you take water, after 1 hour, you will have to go to the restroom, because your kidney knows how much of water you have to take. It will prompt you. That's why you get thirsty. So whenever you feel thirsty, you have to take water. Not necessary that you have to keep up and keep taking the water. So your body is built in such a way that it will tell you, go drink water. That is the time to drink water. But you have to make sure, because of your occupation, especially people who are stone farmers have to be careful. Other than stone farmers, your body will tell you.
Thank you, sir. So we have several questions here. I'll start with just a few. So there is one question here. Are there times within a 24-hour period when the kidneys get hyperactive, producing excess urine and consequent loss of electrolytes?
I would definitely tell no. There are certain conditions wherein there is something called salt losing nephropathy, but the kidney as such keeps functioning normally. There are no excessive functions or less functions because the blood it receives, it's constant. The blood cardiac output is constant. The blood it receives is constant, and depending on the amount of solute or the solvent in the kidney, it does its function.
Thank you, doctor. So what are the factors affecting sodium reabsorption in the kidneys, which is essential to prevent potentially threatening, life-threatening hyponatremia condition? Hyponatremia.
It is hyponatremia.
Hyponatremia, okay. Hyponatremia condition. Would you like to take that question, Dr. Charan?
Hyponatremia, I mean, this is a disease condition, madam, most of the time. Because hyponatremia can occur because of n number of causes. We can't enlist that. Even there can be a problem in intake, there can be a problem in other cardiac problems, liver problems, kidney problems. Anything can finally predispose to hyponatremia. Presence of hyponatremia doesn't mean it's a kidney problem. And actually, the treating physician has to evaluate the cause for hyponatremia. And we have to know exactly why there is a low sodium, whether the intake of sodium is low, or whether there is excess sodium loss in the urine, or because it's a dilutional, because blood is going high and sodium is less, because of diarrhea, where there can be sodium loss. So there can be n number of causes for hyponatremia, and it depends on the cause. And for the respective cause, we will have respective treatment. So hyponatremia, we have to treat based on the etiology. What is causing hyponatremia? Doesn't mean always that if hyponatremia means actually low sodium inside the body. So low sodium inside the body doesn't mean there is a problem in the kidney always.
Thank you, sir. So here is a question from Dr. Suresh Kumar Mishra. What will be the alternative in diet as per the advancement of the diabetic retinopathy in a nephropathy in a patient?
I will, yes. This diet, no, madam. Diet has there are some stages of kidney disease actually.
Okay.
We will call it as from stage 1 to stage 5, and the diet in stage 1 to stage 3 is different from the diet in stage 4 to stage 5. And when then there is a progression of kidney disease, the diet will also change. Because in case of early kidney injury, that is stage 1 to stage 3, we will be asking the patient to have a good fruit diet, because what the main problem, the kidney has to maintain potassium level, has to maintain phosphorus level, it has to maintain calcium level. This we will call it as mineral bone disease. Mineral bone disease, where will be everything will be abnormal. So these all the electrolytes has to be maintained by the kidney. So when there is a early kidney injury, there may not be significant problem with potassium. In CKD stage 1 to 3, potassium may be normal, and potassium can be still maintained by the kidney. So there is no need of excessive potassium restriction, excessive phosphate restriction. Phosphorus is also there in the food. Each and every food, even protein food, all the protein food will contain eventually phosphorus. So that doesn't mean to have doesn't mean we should not take any phosphorus diet. If we are not taking phosphorus diet, even the protein content inside the body will fall, because protein will be added with phosphorus most of the time in our diet. If you are eating chicken, chicken will contain both phosphorus along with protein. Yes, we need protein, but the kidneys are, if it is not functioning, we don't need more phosphorus. So there should be a balanced diet, and balanced diet will differ between the what stage of kidney disease is having. In case of CKD stage 5 or say stage 4, which are advanced kidney diseases, there may be hyperkalemia. They are prone to hyperkalemia. Hyperkalemia means elevated potassium inside the body. So for these people, we will be advising low potassium diet. Low potassium diet will contain mostly all these fruits, except some 3 or 4 fruits. Most of the fruits and fruit juices will have very high potassium, especially banana, coconut water, and these things are having a high potassium. So we will be asking to reduce these type of high potassium diet and high phosphorus containing diets, such as bakery items and strict non-vegetarian food. Most of the foods will have this high phosphorus content, but we should not restrict the phosphorus too low such that protein content will also be low and the patient will eventually become malnourished and he will be thin and bones by the time most of the time what we see in with our patients is the patient wife will be coming along with the patient and she will be thinking, okay, kidney problem, now I should not give anything to him. She will stop giving even a food. I could see people only eating curd rice. They're telling, sir, after kidney problem, my wife is not giving anything. She's only giving curd rice. So that should not happen. There is a thing that on dialysis, even on dialysis, the patient who are lean will die early than patient who are obese.
Oh.
So this much amount of restriction should not happen. And when these people go to number of doctors, they are going to 5 nephrologists and 6 diabetics and 7 physicians. Everybody will be telling that we have to reduce this, we have to cut down on this, we have to cut down on this. Eventually, they will be drinking only water. That also kidney nephrologist will stop asking to drink. So this should not happen. I feel they have to be on right diet. It should not be high, it should not be low. It should be at a balance. There should be a balance in life, right?
Thank you, sir. So Dr. N. Venkateshwara Rao, he has a question. Salt, synthetic or natural, which is a good one for preventive and for kidney diseases?
Madam, I will take this question.
Please, sir.
So I was just briefing about the salt substitutes coming very popular among even healthy people. Like it is known as low sodium salt or table salt substitute, which contains more of potassium chloride than sodium chloride, which we commonly take, known as table salt, which we commonly consume.
Okay.
So this low sodium salt is being promoted because the tendency to develop high blood pressure is lesser, and all the other concomitant ailments which can happen because of high sodium load in our daily food intake. All these ailments can be kept at bay. But healthy population and those with kidney ailment during the early stages who are having a capacity to excrete potassium normally, they will not be having much problem. In fact, potassium intake is known to keep our BP in control. Good amount of potassium intake is known to control blood pressure also. So it is good for those people. But once the kidney function deteriorates to advanced stage like CKD 4 and CKD stage 5, these patients have to be cautious about these salt substitutes because they have a risk of developing high blood potassium levels. Hyperkalemia is it can be a life-threatening complication in such patients. So which stage of kidney disease will determine whether they are at liberty to take these salt substitutes or not.
Thank you, sir. So there's one person here who has asked, the doctor has advised a couple of times human albumin due to low in sodium or phosphorus. Is there any alternative to have diet to avoid medicines? I think he's saying his doctor has advised him to something about human albumin.
I'll take that.
Yes, please.
Yeah,
please,
what I could understand is probably that particular person is losing albumin. That means either he is in a severe nephrotic state. That means he's losing albumin through the urine, or I assume that particular person is on hemodialysis.
Okay.
Very rarely we come across people getting albumin during hemodialysis. So why is it given or is it necessary? What happens during hemodialysis is there is some amount of protein breakdown, and even the protein is lost through the dialysis fluid, which is taken out from the body. So that's what like Dr. Charan was advocating, it is very essential that they take good amount of protein during dialysis, because they have to keep their body and they have to make up for the protein loss, which is lost during the dialysis. So if somebody is very malnourished, only then the supplements will be considered. So if you are receiving albumin, it is not for the phosphorus or the sodium or whatever, it is for the protein content. So you have to talk to your doctor, why is it being given? And you have to check for yourself, is it necessary? Obviously, the doctor will do only which is necessary. That means you must be in a severe malnourished state. You have to look, is this the only reason, or is there any other reason for malnourishment? So when it is corrected, definitely the requirement for albumin will not be necessary.
Yeah, I think he's talking about his father. His
Yeah,
father
his
is
father.
undergoing. Pardon, sir.
His father itself, they have
Yeah.
to check. He has to ask his doctor, why is it being given? I mean, obviously it will be given only when necessary. That means he must be in severe malnourished state. So once the malnourishment is addressed properly, then the albumin requirement obviously comes down or is totally stopped altogether.
Yeah, so he's also asked another question. My father is undergoing dialysis and water intake is restricted to 1 liter, due to which he is having, I think he's not able to pass stools. How can this be handled, he's asking.
Yeah, definitely. It is one of the most important problem which we come across in the dialysis population, because the water intake is not adequate and the stool is not soft, and then they get constipated. So you reach your doctor, he'll give you laxatives, and he'll help you in different ways at there wherein you can be helped so that the stool is passed daily. It's a common problem, and laxatives definitely help. And we have to look if there is another pathological reason. If there is nothing else and it's just because of the water is inadequate, you will definitely be benefited.
Thank you, sir. Dr. Annamalai, here's a question for you. What all should be done by a patient to slow down progression of late stage CKD?
Okay, ma'am. I think the question is like once a patient has reached late stage kidney, what are the things to
reduce
to be done?
progression? Yeah.
So I feel that once we deem it as late, then there will not be any point in crying over spilt milk. So our entire goal is to pick it up very early and stop the rapid deterioration. So once the patient has reached end stage kidney or late stage kidney or kidney dysfunction requiring dialysis, nowadays the terminologies are being formed in Western countries so as to avoid negative connotations like kidney failure. So they come up with these new terminologies like kidney dysfunction requiring dialysis, KDRD. But once the patient is reaching that stage, unfortunately, there is nothing much to save the kidney. It's like Dr. Charan was saying, point of no return. Either the patient has to go along the lines of hemodialysis, peritoneal dialysis, or go and get a new kidney in the form of kidney transplantation. So as even Dr. Krishna was saying, the kidney transplantation per se is also not a cure. It is just replacing the native kidneys function. It does not bring that native kidneys back to normalcy. So it is once a patient has been labeled as a late stage, then nothing much is left to save those two native kidneys.
Okay. So here is another question. A man of 65 years old and 35 years of diabetes and 20 years of hypertension with both eyes normal, no retinopathy now, having microalbuminuria at 300 mg per gram. Can albumin to globulin ratio be reverted to normal? And what diet control should he have?
So, ma'am, I will take this question. Actually, microalbuminuria is one of the early kidney afflictions secondary to diabetes mellitus.
Okay.
So, and the patient or the question, the person who has put up the question has hinted about albumin globulin ratio also. Most of the times, even in advanced diabetic kidney disease, we usually do not expect an albumin globulin reversal. When we find albumin globulin reversal in a patient with diabetes and protein leak in the urine, we want to rule out any other non-diabetic kidney disease, especially in the form of multiple myeloma or paraproteinemia, a bone marrow problem. We want to rule that out before putting the entire blame on the diabetes mellitus. So usually we do not expect albumin globulin reversal in the blood secondary to diabetic kidney disease.
Dr. Annamalai, I'll just interject here.
Yes.
The question was, his albumin creatinine ratio has increased, and can he get it back to normal? How can you do it? That probably was the question.
Okay, albumin creatinine ratio. Okay, then albumin creatinine ratio is okay. That is with respect to urine protein leakage.
Yeah, but can it come back to normal?
Very few patients, if it is adequately addressed, the diabetes is taken care of properly, it can come back. Most of the times, our goal is to prevent it from worsening further.
Okay. So, sir, there's another question here, but I think this will be for Dr. Krishna Chaitanya, I think. This is about transplant. So can a kidney recipient posthumously donate the kidney back to the original owner? It's
Yeah.
called reciprocal transplant, in short.
Yeah, theoretically speaking, yes. Nothing forbids you from doing that, but is it done? No. The simple answer is usually no, because we have to see what was the condition. See, the thing is, if somebody is living with a transplanted kidney and losing his life, it could be usually because of the secondary insult, not because of the kidney, because the kidney is working well. It could be because of a road traffic accident or a coronary event or anything secondary.
Okay.
In that period, we'll try to save the person's life. So theoretically, yes, I cannot tell it's a no, but it is usually not done because we try saving his life, and probably in that period of saving his life, the kidney will definitely take a hit.
Oh, thank you. Thank you. So here is a person, some anonymous person has said asymptomatic with S creatinine, I think sodium creatinine 6.9, which is best. What is the best treatment? Go for renal transplantation or dialysis? And I think sugar, he has got BP, sugar, electrolytes are all, if they are all normal. I think this is more a hypothetical question.
Ma'am, I will take this question. So,
yes, sir.
Just because a person's creatinine is serum creatinine, creatinine is serum creatinine, which is 6.9. First of all, we have to find out whether there is a scope for reversibility or not. Whether this could be an acute kidney injury where much can be done to reverse the kidney function back to normal, or whether it is a chronic kidney disease where nothing major could be done, so that we will deem it as an irreversible state. So before embarking on thinking about the need for kidney assisting therapy or kidney replacement therapy, we have to find out whether is there a scope for reversibility in such a patient. And we have to find out what has caused the creatinine to go up from the normal range of less than 1.2 to 6.9. Once we are able to identify the cause and we deem that this cause is not going to be reversed, then at this point 6.9, he may be very well in CKD stage 5. Then if the patient is eligible otherwise for a kidney transplant, then considering a preemptive kidney transplantation may be a better option.
To add on to that, madam, if some people will be asking us, creatinine is now 6.9. We know that we have to go for transplant. Sorry, we have to go for dialysis. And some people are telling with the transplant, I may die. So I would like to be on dialysis only, eternally. So for those things, I want to confirm that on any day, even though I am speaking for living well with kidney disease on dialysis, I would definitely take attention of the audience that definitely dialysis is better. Transplant is always better than dialysis. Because dialysis, even though it is an artificial membrane, which is removing some amount of waste material, but it never can replace a real kidney which is given by the God. Because kidney will does other functions or like middle molecules and these substances also, which will not be done so accurately by the dialysis. And if we see even the overall well-being of a person, or if we see the lifespan or average lifespan on dialysis versus transplant will be always better than dialysis. So if possible, if a transplant is a possibility, and if they could get a live related transplant, or even for that sake a cadaveric transplant, cadaveric means that transplant, better to go for transplant than to be on dialysis. If transplant is not an option, or if transplant they are not able to get a live related or a cadaveric kidney, then they can continue to be on dialysis till transplant is done.
Okay. Thank you. Thank you so much, doctors. This has been a very interesting session, especially the part where Dr. Sri Charan said that you can actually have a good life even if you're on dialysis, which was like too much for me to even consider. But this has been an excellent session. Thank you all very much.
Thank you,
Thank you, madam.
Thank you.
Thank you.